Good evening, everyone, and welcome to Prophylaxis, Teens and Adherence, part of the National Hemophilia Foundation's Hemophilia webinar series. This new series is supported by an educational grant from Novo Nordisk. Our presenters this evening are Jim Munn and Dr. Ruth Mulvaney. Jim is the Hemophilia Treatment Center Program Nurse Coordinator at the University of Michigan Health Systems in Ann Arbor. He has served as both regional representative and chair of NHF's Nursing Working Group. He is treasurer of the International Society of Thrombosis and Hemostasis Nurses Forum, and has presented lectures and authored several publications on bleeding disorders care. Jim has also worked closely with the World Federation of Hemophilia, serving on the organization's Nurses Committee, and most recently as Program Committee co-chair with the WFH 2016 World Congress. The Congress, which was held in July 2016 in Orlando, Florida, included more than 5,000 participants from around the globe. Dr. Ruth Mulvaney retired in 2014 as an associate professor at the University of Tennessee Department of Physical Therapy, where she was involved in teaching research and patient care. For more than 30 years, she served as physical therapy consultant to the university's Hemophilia Treatment Center and Arthritis and Rheumatology Clinic. She has published and presented on research and management of bleeding and musculoskeletal disorders nationally and internationally. Dr. Mulvaney has worked extensively with the Centers for Disease Control and NHF as a member of the Physical Therapy Working Group and as co-chair of 4 NHF annual meetings. In 2002, she received the NHF Physical Therapist of the Year Award, and in 2014, she was inducted into the Tennessee Physical Therapy Association Hall of Fame. Welcome, Jim and Dr. Mulvaney. Our program will conclude with a question and answer segment. To ask a question, please go to the area in the far lower left of your webinar screen and type your question in the field just to the left of the Send button, which is located in the pod or area labeled Chat. Click the Send button when you have finished typing your question. However, please note that your question will be addressed during the question and answer session at the end of the presentation. There are no handouts for this presentation. However, a recording of this webinar will be available shortly on the National Hemophilia Foundation website at www.hemophilia.org. Without further ado, I will like to turn things over to Jim.
Thank you very much, Annette, for the kind introduction, and to NHF for inviting both Ruth and myself to speak tonight. I also want to really thank everyone who was able to join tonight with this webinar, and hopefully we'll be able to impart some information to you and get some questions answered that you might have out there. So, as you can see from the objective slide, we were really tasked with two things. The first one I'm going to address, and that's describing the risk and consequences that are associated with having hemophilia, and then the importance that prophylaxis might be playing in the prevention of bleeding. And Ruth then will go on to discuss both the evolution of joint damage, which is what you see this big word up there, arthropathy, particularly in the role that morbidities that can be associated with each stage as the evolution progresses, and how exercise, physical therapy, and maintenance of a healthy weight can help maintain mobility, especially in the teenage population. So essentially, you've probably all been told about the risks and consequences of hemophilia A and B at some point in your life. Everyone knows that the biggest thing to worry about, of course, is bleeding. And bleeding in hemophilia is most often found in joints, muscles, and soft tissues. Obviously, it can happen anywhere that there happens to be a blood vessel in the body. But what we see is that when treatment doesn't occur, and bleeding happens, especially into joints, you can get progressive joint damage over time. And as a result of having hemophilia A or B, we have seen a number of patients who have had increased absences from work and from school just because of the fact that their hemophilia and their joint issues have played a role. So that we can address those concerns when we talk later on about treatment that's available for patients with hemophilia. Some of the other consequences associated with hemophilia A and B happen to be that activity levels drop off once a bleeding episode is present. And that makes sense because you're really being told by your treatment center to rest the affected limb, joint, to make sure that rebleeding doesn't occur. So as those reduced activity levels happen, it sort of circles that progression of joint destruction over time, which Ruth will address later on. And there's been a number of studies that have looked at responses from both parents and patients with hemophilia, and many have described psychosocial and emotional concerns as well as the financial constraints that can occur with this disease. So this essentially is a picture, as you can see, of a joint that's had damage over time. And what's happened is repeat bleeding has occurred into this left knee. Normally we like a little bit of a wider joint space, and it's been narrowed here because of the destruction over time. The smooth surface that you would expect in a joint has gone away. You can see it's a little bit irregular. And we start to get some erosion of bone over time as well. These occur as a result of repeat bleeding, especially in scenarios where someone's not treating appropriately or hasn't decided to move on to a prophylaxis regimen. Because the big question is there a way to prevent these risks and consequences? Happily, I can say yes. The biggest thing that we've been able to find from all the research that's been done is that prophylaxis can prevent all of the long-term consequences of hemophilia. And we've seen that in a number of studies. And what happens in patients who are not experiencing prophylaxis is that the total number of bleeds, and especially joint bleeds, will increase as time increases with factor levels that fall below 1%. So as you can see in the chart here, this is the pediatric patient population compared to the adult population here on this graph. And they're both looking at the predicted number of bleeds that will happen in a year at every hour in a week that someone stays less than 1%. And you'll see that that increases. This is pediatric patients less than 6 years of age, and these are adults. In the middle is this comparative chart, which looks at the pediatric patients on the top, again less than 6, versus adult patients over 18, and the potential or the probability of having no bleeds in a year, and that drops off precipitously with the number of hours that you stay less than 1%. There are a number of ways to treat hemophilia, and you guys are very familiar with them. First and foremost, you may decide to choose to treat episodically, which is on demand, and that's only at the time bleeding occurs. I'm hoping that most of you have been exposed to treaters who are recommending prophylaxis, because we'll notice later on how important that is. But there's different types of prophylaxis that are out there, and I'm not sure if you're familiar with all of them. But prophylaxis regimens can be continuous, meaning that that happens from the time it starts to forever, essentially. And continuous prophylaxis can fall into 3 separate categories. There can be a continuous primary prophylaxis, which is started before a second large joint bleed and before the age of 3 years of age. There's secondary prophylaxis, which is again a regular continuous approach that started after 2 or more large joint bleeds, but before the onset of joint disease. Tertiary prophylaxis is then what we probably used to call secondary prophylaxis. It's when people who have established some joint disease over time, and it's used to prevent further damage. And this is something that's very important in our adult population who didn't have access to prophylaxis when they were younger. And the last term is intermittent prophylaxis or periodic prophylaxis, and that's the scenario in which a patient might choose to do prophylaxis during a short period of time, such as after surgery or with a sports season, for instance. What all is included in prophylaxis consideration? Dr. Oldenburg from Bonn, Germany came up with a beautiful little diagram that sort of spells out this concept very nicely. You can see that the three things that you need to consider before deciding on prophylaxis is what trough level and interval of treatment do I need, which essentially results in cost. What are the bleeding triggers that I might have? What's my physical activity level? Am I a very physically active person, or am I a couch potato who has probably less chance of bleeding because of that? Do I have already established joint problems, or is there chronic synovitis present? And the other part to the consideration for prophylaxis is, what's the number of acceptable joint bleeds that I might have? So if you think about this concept, if you have unlimited access to factor, you could probably do some fairly aggressive things because your physical activity can go up, and you might be able to eliminate joint bleeds, but you would do that at an extremely high cost. So those are all the pieces of information that are taken into consideration when prophylaxis is recommended for someone to treat their hemophilia. And who do we think needs prophylaxis? The answer has been quite clear from MASAC for a long time, and what they've decided is that in view of the demonstrated benefits that this treatment process has, it should be started at a very young age in persons with hemophilia A and B, and that it be considered the optimal therapy, especially for individuals who have severe hemophilia in A and B. But are those the only people who need prophylaxis? The answer is quite simply no. There's tons of other people who may need prophylaxis, or at least benefit from it. If you've had any previous history of an intracranial hemorrhage, you should be placed on prophylaxis. If there is the potential for inhibitor development, there have been recommendations that some patients should consider going on to prophylaxis to see if that will help minimize or prevent the inhibitor development. That's still a very controversial approach, but these are some things that treaters have used as far as decision making for prophylaxis. Of course, we want to make sure that anyone who has the presence of joint damage is considered for prophylaxis. If you happen to be a person who is one of the couch potato people whose weight has increased and even maybe don't have severe disease, you could have moderate or mild hemophilia, we may make a suggestion that prophylaxis be included just because of the amount of stress that excess weight puts on joints. If you happen to have other comorbidities such as hepatitis C or HIV, those patients might need prophylaxis as well, because other types of bleeding can occur, especially when there's insults to the liver. We want to make sure that patients who have been having problems with school or work absences, that they be considered for prophylaxis so that we can avoid that issue altogether. And of course, prophylaxis is best to treat patients who are very, very active, and we're seeing that more and more in our younger kids. So is prophylaxis the same for everyone? As much as you might heard, the same sort of treatment regimen occurs for prophylaxis for everyone, that's not the case. We have a number of studies who have looked at prophylaxis. The first one, which was the Hallmark study, was done in Sweden, in Malmo. And what they did was they looked at a number of severe patients with hemophilia A and B, and they put them onto regimens that you see listed here. Essentially, a 48 to 80% correction to hemophilia A patients 3 times a week, and if you had hemophilia B, you got 25 to 40% correction twice a week. And they started this treatment between the first and second years of life in patients that were on the study. And they looked at both orthopedic and radiologic scores, and they were evaluated by the WFH recommendations at that time. And what they found was that it really appeared to be possible to prevent joint damage if you were on an effective continuous prophylaxis regimen and you prevented the factor 8 or 9 from falling below 1% of normal. So from the Hallmark study comes the pivotal study. The Hallmark study wasn't a randomized controlled clinical trial that compared patients who were put onto prophylaxis versus those who were not. This study that was done by Dr. Menko Johnson and several other investigators across the U.S. called the Joint Outcome Study was what we call a pivotal study. And the reason is that it has given us information that's allowed us to go to our insurance companies in order to get prophylaxis covered for treatment. But they assigned boys randomly to either prophylaxis or an episodic arm, and they were treated with an enhanced approach. So not with just one infusion, but every bleed that a child had was treated with an 80% correction as soon as the bleeding was noted, and then they were given a 40% correction the second day and then 2 days after that. And they would continue that treatment every other day up to 4 weeks until the bleed was completely controlled. And we know that from this study, outcomes were much better on the prophylaxis arm, such that the statement that was concluded was that prophylaxis with recombinant factor 8 can prevent joint damage, and it decreases the frequency of joint and other hemorrhages in young boys with severe hemophilia A. The Italians came up with their own study to sort of compete with the U.S. study, and theirs was a prophylactic regimen that was given twice a week, and episodic treatment occurred very aggressively as well. And they found the same information that outcomes were much better on the prophylaxis arm. The Canadians came up with an approach that looks at what we call a dose escalation program. It started once a week, and dosing advances when you have a certain number of bleeding episodes. So after 13 years on this study, the Canadians took a look, and the median follow-up was more than 7.5 years. And that what they found was that the age at the first joint bleed really made an important indicator of whether the more severe bleeding was going to occur. So when you're designing a prophylactic regimen for young boys with severe hemophilia A, you really need to take into account how young were they when they got their first bleed. The Canadians have been able to say that boys treated with this primary prophylaxis approach can exhibit minimal joint damage both on physical examination, and they have minimal functional disability as well. There's been an incremental dosing approach in which the Europeans started, again, very similar to the Canadians, where they did once a week prophylaxis with 500 units of factor 8. And they did it until it was feasible for families to be able to do infusions on their children. As the parents were being taught, that incremental dosing increased to 2 to 3 times a week, and eventually it went to every other day when the patients were on home therapy. So interestingly enough, it was an incremental step, but the dosing you see remained the same, so 500 units. And in that period of time, kids can get bigger, and you would think that maybe their dose should go adjusted upward as their weight increases. But they were still able to find that there was no clinical influence if you maintained a trough level less than 1%, because there were some patients who, even though their troughs were less than 1%, still had good outcome. And the lowest effective factor 8 and 9 really needs to be determined for each patient when you decide to do primary or secondary prophylaxis. A nurse out of Sweden did a study looking at daily dosing with factor, which required 13 patients to go on to what we call a crossover study. So the first 12 months they did their usual prophylaxis regimen, and the second 12 months they did daily prophylaxis. And what they did was made sure that the trough level remained the same or higher between both regimens. So the Swedes are very regimented in making sure that trough levels remain above 1%. So that was targeted the same here. And what she was looking for was the feasibility, how much concentrate was consumed, and was it efficacious? Now, interestingly enough, like you might think, it certainly reduced the cost of factor by 30%, but in the patients who went on to daily dosing, they reported more bleeding events, and they felt that they had a decreased quality of life and increased stress based on the fact that they were having to do an infusion every single day. And the last type of prophylaxis approach is a pharmacokinetic dosing approach. And this was a study that was done, again, a crossover in which you did on-demand therapy for 6 months, and then you followed up with prophylaxis, either the standard dosing, which you had seen before, which is an every other day approach, versus a PK-tailored approach looking at your pharmacokinetics, in which your factor was given only every 3 days. And what they found was that there was comparable safety and efficacy for both prophylaxis regimens, and that prophylaxis certainly significantly reduced bleeding compared to the on-demand 6 months prior. And that PK-tailored prophylaxis is an alternative to standard prophylaxis in the prevention of bleeding. And that's where some of the new products are coming on board. The pharmacokinetic dosing with those products might be able to be achieved at doses twice a week, or sometimes even just once a week if you're, for instance, a factor IX deficient patient. So how does adherence tend to affect treatment and my life? We know that adherence, which is a combination of a worked out plan between patients, families, and the treatment center team, is the extent to which patients then adhere or stick to that regimen. In basic terms, many people would say it's the extent to which patients take the medicines as prescribed by their healthcare providers. And according to the World Health Organization, rates of non-adherence with any medication can vary anywhere from 15 to 93%, with the average estimated rate of 50%. So adherence can be an issue, especially in scenarios where treatment paradigms are very, very complicated. We do know that adherence to prophylaxis is very critical to success, and that it's most effective if factor levels are continuously maintained above the target range, which in some patients may be more than 1%. Depending on how active you are, we may be targeting you higher. And when you skip or miss doses, it causes the clotting factor to fall below the target level, which of course increases the risk of bleeding, which we saw before. The real issues that can occur with adherence are outlined here. It may sound as if it's gloom and doom, but it is not, in the sense that all of these things are essentially preventable, and you have the ability to take control of these issues yourself. The more that you have your own independence and self-advocacy, the more likely you are to sort of shy away or steer away from some of these concerns. We do know that there's a higher divorce rate in marriages in which one partner has a chronic disease. So hemophilia falls into that category. Does that mean that every patient with hemophilia is going to be divorced at the same rate? No, absolutely not. The same with the second bullet point, which suggests that depression happens to be 6 times higher in spouses who become caregivers. What we're trying to say is that as teens, if you can develop a partnership where you have control independently and don't put as much emphasis or work onto your partner, the chances of these things drops off. We do know that many adolescents still depend on parents for daily hemophilia care, and we want that to change. We're working more and more on transition issues for patients in hopes that they will move towards their own independence, and that during the teen and early adult years, not only does adherence decrease, but when patients actually choose to go from prophylaxis to on-demand therapy, their bleeding increases, and their quality of life decreases. What are some of the barriers and motivators to adherence? So we had some investigators that looked at these concerns, and what they found was, as far as the things that motivate people to have great adherence are generally age. We know in our younger population, parents are very good at making sure their children get prophylaxis. And then we saw earlier, as the teens start to take over their own care, sometimes they slip off on that, so that becomes a barrier as well. As far as motivators, if you're able to recognize your symptoms, you're more likely to adhere to your treatment because you want to get those symptoms taken care of. If you believe in the necessity of the treatment, you also are more likely to adhere. And believe it or not, if you have a good relationship with your healthcare provider, that also is a strong motivator for adherence. Besides age, as barriers are concerned, infrequent or absent symptoms may also occur. And what we have found sometimes is in the prophylaxis age, patients and families who've never experienced a bleeding episode might forget to call the treatment center when bleeding occurs, and unfortunately not do a treatment that might be necessary. So essentially falling off from an adherence standpoint there. It certainly is a time-consuming process, and so that becomes a barrier for some patients, especially when venous access is an issue, and you have to use a central venous access device, for instance. And cost also can become a barrier to adherence. Does it really matter in the long run, adherence? Well, the answer is a simple yes. We know that physicians have been reluctant to actually prescribe prophylaxis in patients that come across as non-adherent, and that we know that better adherence leads to less pain in patients. It results in more self-reported joint bleeds in those who are not adherent. We have fewer missed days from school or work in patients who are better at their adherence. And if you are not as adherent, then you get lower physical health scores in the pediatric patient population. So adherence does make a difference. And at this time, I'd like to turn over the slide deck to my partner, Ruth, who's going to be talking about, besides prophylaxis, what other things can we do to help.
Thank you very much, Jim, and thank you to everybody who's joined us, and of course to NHF, who is having us make this presentation available. Well, Jim did a wonderful job of talking about prophylaxis and how that can certainly affect joint health. And I would like to talk with you about 4 other things that are very important. And the first thing I believe is that if you have a condition that is chronic and lifelong, you need to really know about it. You need to be able to manage it. You have to have a good deal of knowledge. So I'm going to start out by talking about your musculoskeletal system, what that is and how it gets injured. Then we're going to talk about how to stay strong, flexible, and physically active. And the third thing we're going to talk about is achieving and maintaining a healthy weight. Then the final one is building a good team with your HTC physical therapist, or if you live far away and don't have someone readily available, how you can build a team with someone near you. Okay, so understanding your musculoskeletal system. To me as a physical therapist, this is a beautiful thing, these pictures of bones, muscles, joints, cartilage, and ligaments. Those are the structures that make up your musculoskeletal system. So this first picture on the left is a beautiful picture if we just took the skin off, took the skin away, and now we're looking at this big, beautiful quadriceps muscle. This is the muscle that straightens your knee. It's the muscle you hear a lot of talk about from physical therapists. And you'll see that the muscle then has this white sheath that runs all the way down and connects the quadriceps to the bone. So when muscle connects to a bone, it's connected by a tendon. And then this big structure right here is the kneecap. You also hear it called a patella. And these white glistening structures around here are ligaments. And ligaments are like duct tape that hold the joint together. Then if we move over to the picture on the right, so we've taken the skin away, now we've taken the muscle away. We've got just a little bit of muscle left there attached to the patella or the kneecap and a tendon attached to the bone. But let's look at this knee as if we're looking, someone is sitting in front of us and we're looking straight on at their knee is bent. So here is the femur. This is what the surface of the femur, your thigh bone, looks like. And if you notice in this illustration, it's covered with white, which is a beautiful illustration of the articular cartilage that acts like Teflon in a frying pan. It's smooth, it's glossy, it's well hydrated, and it glides over the tibia, so you have nice smooth movement. Then if we look at this blue area here, this is an example of the meniscus. You have one on either side, little cartilage disc to make it all move smoothly. And then these here in the middle, you probably hear ACL injuries discussed in terms of football or basketball. This is your anterior and posterior cruciate ligaments, your ACL and PCL in PT lingo. You have a ligament on either side, another one on either side of your knee. These are obviously critically important structures. All right, now if someone turned sideways and we just sort of cut right through the knee and we're looking at the inside of the knee from the side. So here's the femur, here's your shin bone or your tibia, and here's that beautiful cartilage that's so important, makes everything glide smoothly on both sides. This structure here is underneath the kneecap, and this is part of the bursa. And what I want you to notice, the word synovium starts coming up. Synovial fluid is that kind of like WD-40 in a joint. Synovial membrane, here's the culprit to joint bleeds. The synovial membrane is a thin membrane that is inside the capsule of ligaments that stabilize your joint. And the problem with the synovial membrane is that it is highly vascularized, lots and lots and lots of blood vessels. So when it gets pinched or twisted, it bleeds. And as we know with hemophilia, the bleeding goes beyond what an ordinary person would have in terms of a joint. So this whole beautiful capsule, inside the capsule, all these structures get bathed in blood, which is very destructive to all these critically important musculoskeletal structures. And then the synovium also can become inflamed. So whenever you hear the word itis in medical terms, it means inflammation. So then you can have synovitis. So you can see above the knee of this youngster, you can see this is all bulky and inflamed, and there is a condition of synovitis, which is also very destructive to all these important structures. So if you get the chance to look at an X-ray, it's really helpful to kind of know what you're looking at. So here's that same femur, thigh bone. Here's the tibia. And Jim mentioned that it's real important to have a space between these. When we look at this on an X-ray, what we're hoping to see is this nice space. So this is a normal knee, and the space is created by that healthy cartilage that we have there. So that's a wonderful illustration of a knee. Here, unfortunately, is, I believe this is the knee that Jim showed you, a knee that's had all that beautiful cartilage has been, we've got a lot of destruction of it. You have bone on bone, so this is a really severe level of arthritis in this knee, and very typical changes that are described in some of the ways that we rate X-rays. This one is the end result when some people have their joints actually fused. There's little to no motion at all. So this is absolutely where we don't want anybody to end up. Long-term effects of all these bleeds are that there's a loss of motion. A person ends up with weakness and atrophy in all those muscles, impaired sensation, stiffness, pain. And then as physical therapists, we like to talk a lot about function. That's the important thing, is can you stand up and sit down from a chair? Can you go up and down stairs, getting in and out of a car? And with your arms, like this young guy's, arms are obviously a serious problem. That he only has a little bit of bend in his, little tiny bit of bend in his elbow. And he doesn't have enough to really feed himself very well. So if both elbows run into trouble, he's got some problems. Using his arms, scratching his head, buttoning his shirt. Again, these are functional problems that we'd like to avoid, and you can see with this gentleman, older gentleman here, he's got some pretty easily visible problems with his knees. Okay, so in the musculoskeletal system, with hemophilia, the most common joints affected are knees, ankles, and elbows. And muscles are also a big part of the picture. A muscle bleed can have some certainly very painful and also some very serious problems. And some of the common areas that are problematic for bleeds in hemophilia are the forearm, the hip, the thigh, and the calf. And these are also extremely important and need to be the factor needs to be utilized for those as well. So how do all these structures get injured to start the bleed? We know that impact, like jumping off of a structure, a basketball player going up for a layup, landing on his on one leg, strain, lifting too hard or straining really hard, compression and twisting are problematic in terms of pinching that synovium. It keeps going back to that synovium in the joints. And once it has bled, then it swells, which makes it even more likely to be vulnerable for more bleeds. So when we talk about vulnerability, if we could avoid joint bleeds altogether, it would be great, because each bleed makes the next one more likely to happen, more possible, because that synovium gets swollen and pinched. So that's sort of a quick run through the musculoskeletal system and how bleeds happen and the effect they have. Now, that's on the positive side. Let's talk about staying strong and flexible. Multiple studies have been done on people with hemophilia, and there's really lots of evidence that says if you can exercise and if you can stay strong, you will improve your range of motion. And I did a study a couple of years ago with colleagues with people with really advanced arthritis and problems in their joints, and we found that they improved in range of motion, strength, they had a decrease in pain, they could walk further, their cardiovascular system was better. Across the board, exercise really worked, and multiple studies have shown that. So we want to develop a personal plan that involves stretching, strengthening, cardiovascular function, doing things that you enjoy. And for that, the last point we'll talk about is teaming up with your physical therapist and get a good plan for you to establish for yourself. Okay, and then so participating in regular activities, what are some of the things that individuals can do, that anyone can do, and that are especially considered good options for people with hemophilia? Walking is certainly a big one. There are a number of recommendations about walking up to 30 minutes a day, 45 minutes if that's possible. If walking is painful and difficult, cycling or swimming or some other activities like Tai Chi might be appropriate for some of our older gentlemen. Silver Sneakers is a great program that involves a variety of activities, and you can do it at just about any level. For some of the older guys who aren't quite sure how to get back into fitness, Silver Sneakers is a really good option. I mentioned Tai Chi. Tons of research has been done on Tai Chi and how effective it is for balance and strength and flexibility, even for cardiovascular function and pulmonary function. Pilates is popular and is a very good form of exercise because it emphasizes flexibility and core strengthening, which the core is the name of the game in a lot of the fitness routines now. Another thing is if you can't get out and exercise and you don't belong to a gym and you feel like you don't have time to do things, DVDs, getting good exercise videos or downloading good exercise routines at home is a way to do it. Set up your computer, set it up on your iPad, your television, and there are a number of great exercises. This last thing I have here that I mentioned is commercial breaks. If a person will just stand up in every commercial break and do squats or do curls with their with weights beside them, if they'll walk around, if they'll do stretches. If you think about how many hours of your life you spend waiting for this commercial to be over so you can get back to your ball game or your TV show. We've got tons of time to exercise in that. Another break that I like to think about is the microwave break. You put your coffee in there to warm it up. You set it on 30 seconds. You're making your bag of popcorn. You got a couple of minutes. You can do a variety of exercises during that program. Toe raises, squats, stretching, a number of things. So we can all find time to work it in. So let's talk about sports. This is probably the most frequently asked question that I get is, what about sports? And so number one is selecting a safe sport. Low impact, low collision, low contact are the best sports for people with hemophilia. So that eliminates football, ice hockey, some of the ones that are known to be high impact and a lot of injuries. The other thing is to use your Prophy wisely. Talk with your doctor if you want to be involved in sports, and schedule prophylaxis for your most active or high-risk times. So these are certainly wise ways to make good use of your prophylaxis. Play a lower-risk position. In basketball, for example, if you watch, the guy that really gets a lot of elbows to the face and really roughed around is typically the center. Under the basket is where you see a lot of contact occurring. People go up for a layup, they land on one knee, twist their leg, a lot of falls. So under the basket is really not the smartest place to be if you have hemophilia. I recommend to the guys I work with that they develop their outside shot. If at all, they could be the point guard. They're in a little bit safer position. Soccer, obviously, you don't want to be the goalie. That's pretty clear. Baseball, the catcher has a lot of stress on his knees and is very close to the ball and the bat, so that's a relatively dangerous position. The shortstop and the pitcher are also pretty close to fast-coming balls, and the pitcher has a lot of stress on the elbow. So for baseball, I like to recommend that people are in the outfield, second or third base. Those are, I think, a lower risk positions than some of the others. And then get assessed by your HTC physical therapist before starting, because therapists can recommend to you pre-sport conditioning. If they know that you have a bad knee on the left or you've had bleeds on your elbow on the right, you can really focus on pre-sport conditioning, especially the core and the hips. We're learning a lot now about sports medicine. Also utilize recommended equipment like good shoes, good orthotics that have been recommended, elbow or knee pads or different joint supports. And remember that rehab after every bleed is essential. One of the worst things you can do is try to jump back in a sport before your joint has healed. So finding the best fit for fitness is my mantra is everyone can exercise. Avoid exercise when your joints are swollen or inflamed. Stay in the pain-free zone. If you want to exercise but you get to a certain point with your elbow where if you go any straighter it's going to hurt, then don't go there. Stay in the pain-free range. If you've got 20 degrees of motion with your elbow, then lift your weight in that pain-free range and work in that level. And what we found previously with our research study was that pain-free zone increased. After a few weeks, the person now had 25 degrees, or they had 30 degrees of elbow motion. Definitely learn correct form and equipment usage. Go slowly and build gradually. One of the hard things for people with bleeding disorders when they start working out is they really need to progress gradually, and that's not, everybody wants to be great and look great immediately. And rate your joints and muscles daily. I'm going to show you a slide of talk about that. Again, consult your HTC doctor, physical therapist, or staff, and only progress when you've completed each exercise level before the bleed. Other things, forget no pain, no gain. Listen to your body. If it hurts, don't do it. You can expect a certain amount of soreness after exercise, but that's not to be confused with doing joint damage. If it hurts in the joint, if you have swelling and heat afterwards, then that's your trial and error sometimes. That's how you know you did too much. Stay with low-risk, high-gain activities. Again, remember the hips, abdomen, and the spine. The core is essential to good function, especially if you want to be in sports. And pace yourself. Have the patience, even though it's hard, to start slowly and increase gradually. Exercise about 3 days a week for 30 to 60 minutes at a time, and have fun. All right, so rating your joints. A hard thing about prescribing exercise for people with hemophilia is their joints can change from one day to the next. Their right elbow may be perfectly fine with no problems. Their left elbow may have had a lot of bleeds. So prescribing exercise sort of depends on where each joint or muscle is. So a level 0, and this is from the research study that we published in the American Physical Therapy Journal. A level 0 is a joint or muscle that's had recent or frequent bleeds. It's swollen, stiff, warm, or painful. And as we've said before, that's really vulnerable. We really have to protect it, immobilize it, not exercise, not weight bear. These are your acute bleeds. That's not the time to exercise or go back to sports. Level 1 is a joint or muscle it's fragile. It's had the bleed. It may even be a target joint at this point. It's had previous injury, and it can be painful with active or passive motion or weight bearing. But it hadn't had a bleed in the last couple of weeks. So this is the joint that's resolving from bleeds or maybe weakened. And this one, at this point, we can start gentle active motion. We still want to avoid a lot of stress or loading, but we just want to gently get this joint moving again. Level 2, a joint or muscle's had a history of bleeding, and it has mild to moderate impairment, sort of pain, stiffness, swelling, little weakness. Your left elbow's not as good as your right, but it still works pretty well. That's sort of your level 2 joint. No bleeding in the past 6 months. And with this joint, you can go ahead and start with active motion and then slowly add weights in 1 to 2 pound increments, exercise in the pain-free range. Level 3 is that joint or muscle that's really had minimal, if any, history of bleeding, no signs of impairment, no pain, swelling, stiffness, or weakness. And this one, I would usually advise people to go ahead and start conservatively. It's going to be trial and error to get your appropriate level. And again, discuss this with your physical therapist. So here's an example of kind of an exercise program for resistance that was in the again in the study that we did that we came up with, and a level 0. So if you have a joint that's a level 0, this one's got to be protected. No muscle, no exercise. Or the joint or muscle, and no exercise, protected. All right. So now it's kind of started to heal. So now it's in level 1 range. So at level 1 range, let's say that this is an elbow and you could, your maximum, 10 rep maximum before you had the bleed, you could do 20 pounds 10 times. You could move through full range 10 times, and then you were pretty tired. And so that's your repetition maximum. If you could do it 10 times, it's your 10 rep maximum, RM. So now it's a level 1. Let's say you can do 10 to 20% of your 10 rep maximum. So at this point, you could start doing 10 reps with 2 to 4 pounds. Week 3, you see you're advancing. Week 4, 40 to 50%. Now you could do a 10 rep maximum, 10 to 20 repetitions with 8 to 10 pounds for 3 sets. And a set is you've done 10 to 20, now you're resting. That's set number 1. The next set you do 10 to 20, now you're resting. That was set number 2, etc. So you can see, rate each joint. This elbow may be a level 1. The other one might be a level 3. So you can see you've kind of got a different game plan here. It's not perfect, but it's kind of a guideline to help you see. So where do you start with sports and exercise? I've provided some, hopefully some pretty useful references for you up here. National Hemophilia Foundation, of course, has got some great information. World Federation of Hemophilia, that's a typo there, WFH.org. Hemophilia Federation of America. The AAP is the American Academy of Pediatrics. They have a great website called Let's Move. There's another one, Protect the Ones You Love. Childhood Injuries Are Preventable. That's the Center for Disease Control. I have the website there. HealthyChildren.org, American College of Sports Medicine. The Arthritis Foundation is great, especially for older folks who have a lot of these advanced joint changes, which are arthritis. This is a wonderful website. Just they can talk about pain and pain management and a number of things. And then WebMD has a fit.webmd. So those are some resources to let you get started. Now, keeping your weight in a healthy range. The impact of weight on arthritis and joint damage is well known. There's a multitude of studies out there that talk about how even if you even lost 5% of the weight that you have, you can improve on your joints. The Center for Disease Control has a wonderful guideline on talking about body mass index and weight and obesity that I highly recommend. And there's a myriad of health problems that go with being overweight, and those include heart disease, stroke, type 2 diabetes, high blood pressure, even cancer. And we know for a fact that carrying more weight promotes more arthritis. It promotes more joint damage. So keeping your weight in a healthy range is really important. BMI is called body mass index. That's not a perfect standard, but it's a way that we talk about weight. And there for charts for teenagers, body mass index charts for teenagers, you can go to CDC, Center for Disease Control, or American Pediatric Association and get their recommendations. And then if you want to calculate what your body weight is, you can go to this website that I've given you here. All right, so let's talk about body mass index. If you can see the chart that I've got up here now, here's the height. So if you look down this list, find your height. Let's say that you're 5'8", okay? And then across here, find your weight, okay? So if you're 5'8" and you weigh 110 pounds, your body mass index is 17, okay? And this blue, if you look at all these in blue, those are considered underweight. So if you're 5'8" and weigh 110 pounds, you have a body mass index of 17, you're considered underweight. Now, if you're 5'8" and you weigh 140 pounds, come down and you have a body mass index of 21. This diagonal row of black represents normal weight. You could even go up to 160 and you'd have a body mass index of 24. But now, you know, holidays are coming up and all of a sudden it starts creeping up. You're 170. Now you're in the overweight zone. Now you're running into areas that are problematic. And this whether it looks pink or red on your computer screen, your body mass index is 26. You're overweight now based on these charts. And you can see that as your weight goes up, you move your body mass index moves up. And when you're at 29.9, you're still in the overweight, but when you go up to a body mass index of 30, you're considered to be in the obese range. And so 30 to 34 is the obese range. 35 to 39.9 is considered, it's obese, it's a level 2 obesity. And then when you go up above 39, that's considered morbid obesity. These are very, very dangerous levels to be at for all of those health risk issues that we mentioned. Okay, now where do you start with good nutrition? We know that we've really got to have the whole family committed to healthy nutrition. The young kids are not the ones that buy the groceries. They're not the ones that cook it. And it requires a whole family commitment to having good nutrition. So I've given you a number of websites here, Dietary Guidelines for Americans, ChooseMyPlate.gov, the American Association Academy of Pediatrics has great information. Slow Go Whoa from Center for Disease Control. And then there's a really interesting daily guide, the 5210 daily guide, which says you should have 5 fruits and veggies a day. The 2 means you should limit your screen time to just 2 hours a day. The 1 is physical activity. Try to get physical activity for at least an hour a day, and that can be all those getting up during the commercials and exercising while you're wasting time with commercials, or it can be the microwave stretches that you do. 0 is zero sugary sweet soda drinks or juices. The American Pediatric Association has really sort of waged war on sugary beverages and the problems that they cause for us. All right, so teaming up with your physical therapist. Your physical therapist, especially if you have one at your HTC who knows you well, is your best ally, I think, for this second portion of preserving your joints. If you don't have a physical therapist at your HTC, we're going to talk a little bit about that. How, what do you need to do? So here's how you get started. You talk with your doctor, and you sort of get exercise approval, and you can get a prescription for a physical therapist, either the one at your HTC or one that you know, to be able to work with you to provide a good, solid foundation. Get an individualized evaluation. We found out in our study that that's critically important. You can't really give a blanket exercise prescription for someone with hemophilia. Know that you may need to modify and adapt some of the activities. We had folks who wanted to do cardiovascular, but they couldn't ride a bike because they didn't have enough motion in their knees, so we got them into swimming. We also got them into cross-country ski machines because they could do really good activity with a limited amount of range of motion in their knees. So get your sports recommendations, splinting, bracing, protective gear, and go for it. Okay, so the teaming up with your physical therapist is really, communicating is so important. Let that person know you're thinking about going into a sport. Let your therapist know that you really do want to start toning up, you want to start dropping some weight, you want to start getting more fit and more healthy. And let your therapist work with you. Set goals together, make a plan, and then stick with the plan. Now, if you have a physical therapist in your community, you don't live near to your HTC, and you can get a prescription from your doc, that person can help you. But first you've got to be the communicator, and you need to provide resources to that therapist because, as probably most of you know, not everybody knows about hemophilia. And once a physical therapist has been connected with the National Hemophilia Foundation Physical Therapy Working Group, they've got an ally. We're on those of us in that group are there for people to be able to call us and for us to be able to give advice and give suggestions and give references. NHF has, and the other sites that I gave you, World Federation of Hemophilia, Hemophilia Federation of America, they all have really good information, so share that with your physical therapist. And then get instructions from your own HTC therapist who can work with you to provide information to that person. Okay, so the take-home message then, teens, it's time to listen up. Respect your joints and muscles. I know so many older individuals who say, boy, I wish I'd have listened. And maintain strong, flexible musculoskeletal system. Know that everybody can exercise. If you're overweight, if you're stiff, if you have bad joints, it doesn't matter. You can exercise and be physically active. I promise you that can be done. Choose your sports wisely, maintain a healthy weight, and team up with your physical therapist. So those are my suggestions, and I wish everybody the very best of luck. And I think we've got a little bit of time now to open up for questions.
Excellent. Ladies and gentlemen, to ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen, then type and send your question. If you would like to ask a question live via your phone, please press star 1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, take it off mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod in the lower left corner of your screen, then type and send your question. To ask a question live, please press star 1 on your telephone keypad. Excellent. We do have one question. Jim, this is directed towards you. Do you think adherence in teens might improve in the future when there are treatments that do not require venous access? Venous access?
Yep.
Mm-hmm.
All right. Well, thank you very much for the question, whoever submitted that. I think that we've always had this desire to improve routes of administration. So the desire to go, for instance, from venipuncture to sub-Q injections to maybe even oral preparations has always been on our docket, so to speak, because we do believe that when you make any regimen easier, that adherence improves. From that standpoint, I do believe that teens are going to get better with doing the actual sub-Q injection instead of needing to do venous access. That I do believe is probably going to improve, but I think we're going to fall back onto what we found as a barrier earlier, and that was when you have infrequent bleeding episodes or you don't recognize what's happening, adherence tends to drop off. So my fear is that although patients may be taking their subcutaneous injection, if they're not recognizing bleeding episodes and then treating those appropriately, because these products that are going to be given sub-Q may not prevent all bleeding, and if you have never recognized it for a few years, let's say, and all of a sudden you tweak your ankle, you may go to bed thinking, oh, it was just an ankle sprain and I'm fine, and wake up in the morning with a devastating ankle bleed going on. So my fear is that we're going to potentially change one scenario for another, which is what has happened with prophylaxis, and I mentioned it in the presentation as well, that even prophylaxis has changed that piece for some families. Families who grow up without any hemophilia in their family, who have never experienced bleeding episodes, who have had their child on prophylaxis for years and years, sometimes forget that injuries do result in bleeding that need to be treated, and we still get occasionally calls from families who didn't let us know that, for instance, a hip was bothering somebody for a couple of days before they called us, and then we find out that there's a hip bleed going on. So adherence falls into a couple of things. Yes, I think they're going to be adherent to the actual subcutaneous injection regimen, but they may not be adherent to treating when they have a bleed that they, for the first time, aren't recognizing as really a bleed.
Excellent. We have no further questions at this time. Thank you to our speakers. Your feedback is critical to us, not only in evaluating this presentation, but in the planning of future webinars. Please complete this 5-minute survey appearing on your screen shortly by clicking on the link. Thank you for attending. This concludes our program.